Good morning. Appreciate the opportunity to speak today. I'm going to keep my remarks pretty short so you can hear more from these two folks that are leading health centers in different parts of Michigan. But quickly, we'll introduce the Michigan Primary Care Association. We've got the pleasure of serving as the voice for 48 health center organizations across the state, all of Michigan's federally qualified health centers, many of our tribal health centers, urban Indian health programs, and several community-based healthcare providers. Just a sense of scale, we operate over 400 locations across the state of Michigan and serve 1 in 14 people in some form of primary care, behavioral health, substance use, and oral health services. On January 28th, which is technically the day before that memo came out, I will always remember the first time I saw it. It was leaked a little early, the day before it was implemented. But on January 28th and in the days following, every Michigan health center, like many community organizations, were impacted by the announcement of a federal funding pause. Through most of that day, we had a lot of confusion about what that pause meant. In the days following, most organizations were really facing significant uncertainty about a critical part of their resources. Health centers are funded in lots of ways, but federal resources are one of the most consistent places that they're funded, and also an area that's really important to paying for health center workforce, the folks that provide care day to day. While the federal funding pause did get officially rescinded not long after it was put in place, it wound up taking over a week for the federal payment management system to catch back up or restore to more usual operations, and most health centers to begin receiving access to federal funds again. But for some health center organizations, it took 2 weeks to regain access to federal funds. We often talk in week timeframes when it comes to federal grants access because different things happen at different times. About 2 weeks out from a health centers not being able to access funds, we had a few, about 3 health centers in Michigan, that were going to face an impact on patient services. When we get to 4 weeks, that number goes up to almost a quarter of the health centers in Michigan would have some impact on patient services. When we get to 6 weeks, it's 2/3 of the health centers in the state that would impact patient services. And that means consolidating locations, providing less services of the people that services that people need. During that time, during the period of that pause, health centers engaged in conversations with HHS, with the payment management system, lots of time spent on the phone with folks that press the buttons for those federal grant access. We spent time with members of Congress, with many of you, really trying to restore the situation. And we did. Today, we have mostly normal operations when it comes to federal payment management and grants access. I say mostly normal because many federal grant drawdowns are still taking longer to process than they would normally, and drawdowns that may be for a higher amount than is perceived as normal, where there are normal variations in budgets throughout the year, are often still being manually reviewed. Leading up to this pause, health centers had faced a pretty significant number of financial challenges, everything from the erosion of 340B savings, which we're grateful for the Senate's action on, to stalled insurance payments from insurers, the uncertainty around stability of federal funding. So there were a lot of challenges leading up to this point in time, but adding a federal grants pause on top of those existing challenges really exacerbated an already difficult situation. So with that introduction, I want to turn things over to Deb and then to Megan to talk a little bit about what it looked like for their health centers.
Good morning, everybody. I want to thank you for the opportunity to come in and share kind of a disheartening situation, which I think is really important to understand from that perspective. I'm Debbie Brinson. I'm the CEO of Honor Community Health Center, which is located in Pontiac, Michigan. We serve Pontiac and the greater area there. We are also important to note that we also are the first FQHC in the state of Michigan to run a residency-based training program for family physicians, which is really important. It's important to know that we employ 180 people and 18 family medicine residents. We have 11 primary care sites, 9 school-based health centers, and 1 dental clinic. We serve more than 30,000 individuals each year and have more than 90,000 visits coming into our center each year in those areas alone. My organization is a nonprofit, and there are three primary ways in which it gets funded. The first is from revenue from Medicaid and Medicare reimbursement, and then from state and federal grants. Those grants include from HHS, they include from Ryan White, Title X, SUD, CMH funds. As you can hear, these funds are our lifeline to our ongoing operations and to the delivery of care in our community. Equally important, they're the lifeline to employees' paychecks coming in, 180 of them coming in. I think it's important to share my age, because I would bet that I'm probably one of the oldest people in this room that's worked with HHS. I've worked for more than 30 years in the health and human services field, either through local, state, government, and or to the most recent in the last 15 years as a nonprofit. And during that entire time, I've worked with HHS in some kind of capacity. During that time, in the last 30 years, I have never experienced a situation as I did in January, which is where the payment management system stopped, completely stopped without any kind of warning. As an employer, incredibly scary. Incredibly scary to not know what's going on within 2 days of being able to make payroll. Now, it's important for HHS for you to understand. In HHS, it's not simply that I can go into the payment management system and make a request to draw down. There are very stringent requirements being able to go in and make a payment. You can't do 3 days beforehand. That money's got to be expended out either 3 days before or 3 days after. So most of us in the FQHC world use that payment system to make payroll. It's very clearly defined. And we have outside auditors that come in and take a look, are we meeting those stringent requirements pieces? So for that first week, first time ever, have I tapped into my reserves, which I'm grateful for having, and being able to make that payroll. So I tapped into reserves twice in that down period without having any clear understanding of what was happening on that piece of it. Systems up, am I still concerned? And I want to share with you yes, and let me share with you why on that. We still have not received approval of a $600,000 carryover that must go into this budget. We still not have received that approval from HHS. And other times, we would have received that payment approval within 4 weeks period. It's still 6 weeks out. We've not heard any indication from the help desk because there's no help desk for us to check in with. While we're getting the payments, the algorithm is different. So when we went in to make a payment request for the payroll that we missed and then had to make a payment request for the payroll that we needed to, it stopped. It said we have to go through multiple levels of approval. So we did that being a good faith partner in this. We understand the complexities of any structural situation, but that still continues to this day. It required us to tap into reserves. And why that's really important as a nonprofit, I keep a certain amount of operating reserves on hand. Those reserves are going to change dramatically because we know that there are additional changes coming about, and I, as a leader, must be prepared. That is what the board expects from me, is to take a look and to put the organization to make sure that it's on good standing. Those reserves are very important to us. It fueled staff concerns in a way that I have never, ever seen in my last 30, 40 years in the career. All of a sudden, I had people in my door that I don't ever see, frontline people coming in and saying, am I going to have a job? And I have said to them, yes, as best as I can do that, you will have a job. And if you don't have a job, I will be the first one to personally tell you that you will not have a job. But right now, you have a job. And I get paid to make sure that you have a job so you can deliver services on that. First interview question coming in is, are you grant funded? Yes, we're grant funded. What does that mean on that? That is the first thing that applicants are asking coming into the place. We're already stretched for frontline and MA staff on that. This did not help the situation. And finally, I just want to share with you the lack of confidence in an infrastructure that I have come to depend on and others have come to depend on. I can't make good decisions and I can't be held accountable for making good decisions when I can't trust that that's there. And I'm going to give credit to my son who said, Mom, part of what I'm struggling with is there's a yellow line that goes down the road. And we all agree to abide by that yellow line driving down the road, that this group will stay on this side and this group will stay on that. There's no magic buzzer that says when you cross over, you're going to get in trouble. There's an agreement between us. And that's exactly the same thing with the infrastructure. My agreement with you as elected officials, my agreement with those administrators with HHS, that if I receive this money, that there's an agreement I'm going to use that money appropriately. And on the other side of that line, that HHS or others will also follow that same agreement. Otherwise, I can't do predictable problem solving. I can't deliver care on that. When we go over that line, who brings us back? In the local community, it's the police department, it's somebody tooting their horn saying, get over on the other side. But still, there is this basic premise that we will all agree to how to operate. And that has changed for me. I've never encountered a situation like this where that's changed, where I have to be predictable. I don't have a way to be predictable anymore, nor does my board have a way to hold me accountable for being predictable. Long-term impact, there will be long-term impacts on it. I am seriously looking at consolidating sites. I don't have a choice. There are lots more changes coming in, and my board expects that from me on that. I'll be using more reserves, and I'll be going out for more grant requirement pieces with that, which every other group will be doing. But structurally, we have to figure out how this is going to change because we play a really important role in the delivery of care. My final comments to you are, I'm a nonprofit, and I'm really proud to work in a nonprofit. I'm an integral part of the system of care, integral part. If I were to be removed from that integral part, it will have a major, major, profound impact on hospitals, on local law enforcement, on communities because of that. But you have to understand, as a nonprofit, my margin is less than 3%. Less than 3%. And most of my money goes out into delivery of personnel costs in order to deliver care to individuals. That's an important piece of this. I don't have deep bench. I don't have deep resources. And so when those are hit, it takes a major, profound impact on us. Thank you for the opportunity to share.
Thank you. Thanks for allowing us to be here today. My name is Megan Erskine. I'm the CEO of Catherine's Health Center. I agree with everything that Deb said, so I'll probably keep my comments a little shorter for the sake of time. Catherine's Health Center is a federally qualified health center in Kent County. We have locations in Grand Rapids, Wyoming, and Kentwood. We've been growing a lot. In 2021, we had 1,000 patients, and at the end of 2024, we had 6,000 patients, but we're still fairly small, which allows us to be nimble and agile and innovative, which is what I want to talk about today. Catherine's provides care to all community members, all low-income community members, but something that we're really proud of and that we're specializing in is healthcare for the homeless. And the way that we do that right now is we go into 3 different shelters in Kent County. We go into churches. We're doing place-based care out of encampments with our street medicine program. Over 30% of our patients are homeless, even though that definition for us is fairly broad. Our healthcare for the homeless program exemplifies what we believe at Catherine's, that healthcare is a human right, but we've also had an integral part in decreasing overall healthcare costs in Kent County. I want to talk about one of those projects today. We have an innovative partnership with the Women's Shelter in Dégagé. Dégagé was able to offer housing to 24 chronically homeless women with very severe mental health and physical health issues. These women have been in and out of shelters and hospitals for literal years. Catherine's provides psychiatric and medical care 8 hours a week. After 1 year, we saw a 72% decrease in emergency room visits, an 87% decrease in EMS visits. There were 5 inpatient hospitalizations in quarter 1. In quarters 2 to 4, 0 inpatient hospitalizations. And as of today, 100% of those women are still housed. Consider the impact that has on both taxpayer dollars, overall healthcare costs, and just the quality of life for these women. I don't bring this up to brag, but maybe I'm bragging a little bit. But this unique program relates to 2 of our new federal grants that we received in 2024. We were very lucky and fortunate to receive 2 grants from HRSA. One grant would allow us to hire a full-time street medicine team and a van to go into more shelters, do full-time care, go into homeless encampments. And what we're most excited about, the second grant would allow us to hire a full-time medical, dental, and behavioral health team in the largest shelter in Mel Trotter in Kent County. Currently, the way that we're doing healthcare for the homeless, I'm pulling other providers from my community clinics, and we're doing some hours there and some hours over there, and it's been really great, but it's patchwork. These 2 grants would absolutely escalate and scale up the work that we're doing in a way that would transform our community. But because of the federal funding freeze, we're taking a much more conservative approach to that funding. While we are still committed to healthcare for the homeless and we are still committed to meeting the minimum requirements of that grant, we are taking a giant step back from that original vision. I do not feel comfortable hiring brand new full-time care teams because I'm not even sure there's going to be a second year of funding for the grant. So we will likely put internal staff on these grants. This is such it's a disgrace, and it's sad, and it's a tragedy for our community because we've already talked to partners about the work and this vision, and people are very excited and looking forward to what we were going to be able to offer. And now we are taking a risk-averse approach. We are shrinking, we are not growing, we are not transforming. We also have a base grant as well, and I won't go into or repeat what Deb said, but I do just want to echo the workforce concerns in general. I've spent the last 6 weeks meeting with staff who are concerned about their jobs. I've lost 2 candidates for medical providers that found out that we are federally funded and declined jobs. It is already really hard to get people to work in an FQHC because it's really hard work. It's mission-oriented work, but it's really, really hard work. I had to go and spend a lot of time securing a line of credit at a bank because we also used the grant to make payroll. We were lucky that the federal grant eventually came down, but just a lot of my time in the last 6 weeks and a lot of leadership's time has not been spent on core mission or being efficient or effective. We spent a lot of time in meetings with elected officials, which we love to do, our staff, our community members, our board, our partners, and it's all figuring out contingency planning. I think it's heartbreaking. I think FQHCs are one of the most spectacular nonprofit models in the United States of America. I'm proud to work at an FQHC. I'm proud to work in an FQHC in Michigan. And it breaks my heart that we are shrinking and we are not growing and we are not moving towards progress. Thank you very much. I really appreciate your time today.
Thank you, Mr. Chair. Thank you all for being here. I just want to state for the record, because I think this is, all right, I got too aggressive. I think there is a misunderstanding about federal dollars, that somehow it's a handout or it's putting our state in debt. To be very clear, and the chair alluded to this, these are our tax dollars that we pay to the federal government that then come back into our state to serve the people of Michigan. I had an opportunity to spend some time at Advantage Health in Detroit, our FQHC in our area, and I'm glad you brought up how you interface with hospitals or other community organizations. I had a coffee hour just this last week, and a woman attended who works for a clinic who said, you know, beyond the uncertainty of the funding, she called over to the VA, as she often does, because there are people who get service from multiple organizations and couldn't get a call back. That people had been let go, people had been fired, that the people who still were there weren't sure what they were able to do anymore. So I'm wondering if you could talk just a little bit more about how you interface with other community organizations and particularly interfacing with hospitals, because without FQHCs, many of these patients end up in the emergency room correct? When you're waiting, not preventative care, it's waiting until a situation gets so bad that you're in the ER. And I know we've had conversations in the last committee here about bringing costs down for the rest of us. Hospital visits are incredibly expensive, and that cost is passed on to the rest of us. So I'm wondering if you can just talk a little bit about how you interface with other organizations, and not that I want to ask you to go to worst case scenario, but what happens if you close?
So for us, we have a really strong partnership with all the hospitals in Oakland County, particularly in Pontiac. So if we were to close, the first thing that would happen is those patients would end up two places, one in the emergency room or in jail. We just did a joint initiative to open up 7 days a week, 12 hours a day with our local county health department and with Trinity to be able to see as the first stop for individuals coming in before they end up in the emergency room, or for a location for the police department to bring in an individual. So for us, it's huge. The cost, I think, there's a lot of cost studies out there that would show the impact on that. But beyond that, it's the primary care and the loss of lives, quite frankly. I mean, I think looking at what happened during COVID, FQHC stayed open when many primary care docs' offices stayed, and the hospitals were taking care of individuals as they should. We need strong partners. We need strong hospitals. We need strong FQHCs. We need strong local health departments. All of us play an integral part, and if you remove any one of those pieces, it has a domino and cascading impact, and it's not a good impact. The great thing about all of these systems is when we come together and we work on a system of care piece. That's how you reduce down costs.
Thank you. I do want to get to other questions.
Yep.
Are there other questions?
Thank you, Mr. Chair. Ms. Brinson, did you say there was no help desk at HHS?
So there are opportunities, and I'll let Philip address this more, but there are help desks within each of the systems within HHS. So the payment management system has one.
I guess let me rephrase.
Okay.
I don't mean to interrupt you, but we have lots of people. So did the service that you were used to having from these help desks take a nosedive after the announcement? I guess
Yes.
Yes, thank you.
Thank you, Mr. Chairman. Thank you all for coming in and talking today. A lot of what you've shared is impactful. I want to focus in on, and for anyone else who's going to testify, I may ask the same question, so you can feel free to include it in your testimony. But top line, so we can understand this, from when the funding freeze happened till today, how many federal dollars that you're entitled to have been kept from you?
Yeah, go ahead.
I don't think in our membership we've had any federal dollars completely withheld. What we have seen is the ability to access those federal dollars operate on a very different kind of time frame. So very quick. Normally, to access a federal grant, you submit what's called a drawdown request. So you say to the HHS payment management system, I would like to take this amount of money that I've been awarded or from the amount I've been awarded and deposit it into our bank account to pay payroll or pay other expenses with. And usually you would submit that. I'll use today as an example. So I could submit a request right now and it would be in a bank account tomorrow. What happened during the federal grants pause is there was a period for most health centers that was about 5 to 7 days where those requests were not funded. So you would put it in, it wouldn't show up tomorrow, it wouldn't show up the next day, it wouldn't show up the next day. For some health centers, that period of time lasted as long as 2 weeks before they had put in a request and then actually saw that deposited into their bank account. We've not, in our organizations, had federal funds never show up, if you will. So at this point, we are still waiting on some to be approved, but we haven't had any be declined, if that helps.
So I do want to clarify, we do have a request in that's been in for 6 weeks to do our carryover, which is a less than $600,000, and we still have not received that approval.
And it is unfortunately far from the only one that is still in that pending. Hasn't been declined, but it is out there.
You're welcome.
Thank you very much.
Thank you.